Si vamos entrando, así podremos, ya que hemos recuperado el tiempo gracias a Joyce y a Sebastián, que nos han marcado un poco los timings más claramente. Vamos a continuar y tengo el placer de presentarles a la doctora Joanna Robson, que es profesora asociada de reumatología en Bristol, en Inglaterra, y nos va a hablar del impacto que los corticoides, otra vez, los corticoides tienen, el impacto que tienen los corticoides en pacientes con enfermedades raras y el impacto que tienen sobre la calidad de vida. Pues ella es una especialista que ha trabajado mucho tiempo en todo esto y seguro que lo que nos explica nos va a ir bien no solo a vosotros, sino también a todos los profesionales. Y otra cosa, perdón, al final, si queréis preguntar alguna cuestión, yo se lo puedo traducir.
Okay, so thank you very much, Maria, and thank you for inviting me to talk at this really interesting and exciting conference. I'll give everyone a moment to adjust their earpieces so that you can hopefully understand me. So, yes, I'm Jo Robson, I'm from Bristol, I'm a rheumatologist, and I'm also a researcher, mainly focused on quality of life in vasculitis. So I'm going to talk to you about the impact of steroids from the patient point of view in terms of quality of life, and also the impact of having a rare rheumatic condition and how that can have an impact on quality of life as well. These are my conflicts of interest. So yes, firstly I'm going to talk about how we've developed a patient-reported outcome measure to try to measure the impact of having steroids for your rheumatic condition or vasculitis, and how that impacts on sort of activities of daily living, psychological impact, joining in with things, etc. As part of that work, we've also done some more focused work on the impact of steroids and how they can lead to changes in appearance, weight gain, facial changes, and how that then has an effect on self-belief and self-confidence, and how it can really impact just the change in appearance can also impact on quality of life directly. And some work that we've been doing around sort of the education of healthcare professionals about talking to patients about these side effects and warning them in advance. And lastly, if we've got time, we're also going to talk about the impact of having a rare rheumatic condition, how it can take a long time to get a diagnosis, how you can feel very isolated, sometimes family and friends and even doctors and clinicians have not heard of the diseases which people are eventually diagnosed with. And in the UK, we're doing a programme of work to try and develop a support intervention across some of these rarer diseases, so vasculitis, but also things such as lupus and myositis. So my interest in steroids and their impact on patients started when we were developing a patient-reported outcome to measure the impact of having ANCA-associated vasculitis. And a part of this, we interviewed 50 patients from the UK, USA and Canada, and we got them to tell us what was the most important things to do with having vasculitis that impacted them in terms of their quality of life. And the resulting interviews were analysed in a lot of depth, and it resulted in a questionnaire which we've now used in studies and trials to try and measure what the impact is on patients. And one of the big domains that came out, so the 6 domains that we resulted in, a few of them were about the actual disease activity aspects, like the ear, nose and throat, the respiratory problems, the fatigue came out as a massive thing, also impact on physical activity and strength, so as we were hearing about already about the frailty side of things, impact on psychological and social side of things came out as a big thing. And also the fear of the future came out as a whole topic in itself. So just to sort of reiterate what the patients were talking about just in the last session, this is all things that those 50 in-depth interviews from across the world really came out with very similar aspects. But one of the really big topics was the impact of steroids. So people wanted to tell us about how they had a love-hate relationship with steroids. As we've also heard, sometimes there's a long wait to get a diagnosis, and when somebody tells you, yes, we know what this is and we're going to start you on treatment, the steroid works really quite quickly in most cases, and there's a switch off of those symptoms and also a relief at finally getting the diagnosis. However, that's followed by short-term impacts from having steroids, and also those fear of sort of longer-term impacts as well. You then you get more of the picture of the idea that you have to take further medications, and this can all impact on the number of medications you have, the number of infections, and everything that Louis-Philippe was talking about earlier in terms of those side effects. So it really is a balance with steroids being so essential to control sometimes quite life or organ-threatening disease, and the fact that they work quickly versus the fact that they can have all these side effects. So this led on to us becoming very interested in trying to measure those side effects so that we can try and aim to reduce it in the future. And I'm part of an international consensus conference working group, which is made up of patients and clinicians and researchers focused on glucocorticoids, which is sort of the scientific name for steroids, and how do we measure those. And we've come up with a number of different domains which should always be considered. So things such as infection, that risk on bone fragility, mood disturbance, high blood pressure, diabetes, weight gain, fatigue, and also other aspects such as sleep and change in appearance. We undertook like a big review of lots of other studies that had already happened, and there was a lot of different aspects that patient reported. So physical symptoms, such as weight gain and sleep problems, psychological symptoms, such as mood swings, the burden of having to take other tablets to prevent other side effects happening, and that cognitive load, so that having to take a tablet that you're also being told is slightly sort of dangerous for you as well, and how this can all affect participation, work and social interaction, etc. Also, there's a lot of contextual factors around steroids. So certainly in the UK, and from experience of talking to patients from other countries, there's some real fear factor around steroids. So patients might experience their family and friends, and even some doctors being quite fearful of the fact that they're on steroids and saying, well, you must try and get off them, but obviously also needing to actually take them to keep the disease under control. So there's a lot of different aspects to consider. So we decided to develop a patient-reported outcome specifically to try and measure the impact of steroids. So this is something called a conceptual framework, where we got together with our patient partners and our clinicians and researchers, and we said, what do we want to measure as part of this questionnaire? We want to measure those psychological symptoms, the physical symptoms, that really big concern about comorbidities or side effects, the concern about flaring of the disease if you reduce the steroids, how all of these things can impact on your function, so ability to join in with things you want to do, like work, family life, social life, sense of self internally, hobbies and tasks at home. And this was what we decided with our patient partners and the other clinicians and researchers that we should try and focus on. So we did, I think it was 60 interviews for this study with patients in the UK, Australia and the USA. And these are some of the quotes. So about the physical symptoms, the fact that people found, so I'll read a few of them out because they're in English. So this is a young girl talking about when she'd got lupus. So this was also a project which we asked people with vasculitis and lupus as well. A young girl talking about when she first was put onto steroids at the age of 17, about how she went back to college after missing a term, and then people calling her chipmunk because her face had changed and she was very bloated. We've got a patient from the UK who had Churg-Strauss or EGPA, talking about the psychological aspects. I was like, I was wired all day long is the only way to describe it really. I did the decorating 2 o'clock in the morning because I couldn't sleep. So people talked as if they suddenly had this massive amount of energy, which was good in a way, but really quite disturbing in another way. We had a patient with GPA from the UK, talking about feeling socially very reluctant to go out because of that change in self-appearance, etc. And a patient with lupus again from the USA, talking about how the energy level is really high and you're bouncing around like a rabbit. I can't be quiet, I'm just very talkative. Also had some impact on participation. So we had a patient who from lupus from Australia saying made them feel very insecure, is very scared to apply for jobs. I become quite uncomfortable with the fact that I have lupus and I'm on steroids. another patient from America talking about how their personality had been impacted by steroids. So somehow I overdraft my bank account by $500, and in 20 years I've never done that, and I felt confused. I would be looking at something and it would take me a long time to figure out numbers. So people were very much more impulsive than usual, really out of character for them. These ones I won't read out again, but really there's a massive impact from taking steroids just alone. So with the patient-reported outcome, we get all of these long list of different topics, and then we test them with lots of other patients to see whether the topics are really important to them and how to phrase that in a questionnaire item. So we did that, and we reduced the number of items, and we also tested it to make sure that you could translate it into different languages in the future. And then we did a large-scale survey with a bigger group of patients. So the initial domains that we came up with were very similar to the systematic review about the physical and psychological symptoms, and also the impact of participation on relationships. People talked about how they were very short-tempered with family or friends and work. People got into road rage situations where they'd never ever got into situations like that before, and also some of the benefits of steroids, of course. And this is kind of just a mock-up of what the questionnaire looked like. And our validation survey was performed in almost 1,000 patients online from the UK, USA and Australia. And this was across all of the different types of people from rheumatology who normally take steroids. So vasculitis, giant cell arteritis, all of the different ANCA-associated vasculitides, also lupus and inflammatory arthritis. And we partnered with lots of the different patient groups. So Vasculitis UK was incredibly supportive, and RARE in the UK, and all the individual disease associations that support patients or publicise the study. And through this, we were able to do some statistical analysis to reduce the number of items down to 15. And the really key domains that seemed to come out was the impact on appearance. So again, what people mentioned at all, again, about the weight change and the appearance change being so crucial to people's sense of self, when you've also been diagnosed with a new disease and you have to cope with that, was really impactful. This impacted also psychologically, also the social impact of not wanting to go out and do your usual work or social aspects. And treatment concerns. There was a whole domain just about the fact that people were annoyed about having to take additional medications, just not just the steroids, but also things to prevent sort of bone loss, stomach ulceration, osteoporosis, etc., and infection, of course, as well. And the fear of the future. What did it mean to be on these steroids? Would you ever get off, etc.? So this then was tested in this survey, and we found that it does seem to have a lot of validity. So there was differences in the questionnaire scores between people who are on high doses of steroids versus low. And statistically, it looks like it's it's a very reliable scale, which means it should be suitable for use to either help people communicate with their physicians. So if they go to an appointment, we're now going to try and test whether it will help with communication, because we feel like it will bring up things that maybe the doctors wouldn't normally focus on, like the impact of appearance, etc. But also in clinical trials as well, to actually measure that impact of steroids on people's quality of life rather than just the dose of the steroids. So as a follow-on from this project, we also asked our patient partners, we have all of this patient data, if there's one thing that you would like us to look into in a bit more depth, what would it be? And they came back very strongly saying the impact of appearance and weight changes due to steroids. So one of our researchers from Nottingham has been looking into this in more depth, and has a poster here at the Vasculitis conference. So what she did is she went back and looked at all of the different initial interviews in depth and analysed them again. So this is the same participants. And what she's found is that there's three really overarching themes that came out when she looked at them. Firstly, people reported that there's a real pressure to conform to societal ideals, which can vary depending on cultural background and gender. But we've got here societal norms. So the quote that one of our patients used to sort of explain this was, "I don't think anyone really likes gaining weight. There's a part of you that thinks that thin is better." And this is a female aged 27. There's also an impact directly on mental health, and it seems to interact from if your appearance changes, and also the steroids, as we know, can impact your mood directly. Having those two things together can just sort of double the effect. People reported that they didn't feel like they looked like themselves, and this could be associated with changes in mood and self-confidence. So the quote here is, "It makes you feel down, it makes you feel depressed, you don't want to socialise because you're not you." So we also had another domain which was about burden of adjustments. So the quote here was, I have a wardrobe right now that goes 4 different sizes, as well as my weight goes up and down. So they'd open the cupboard and some clothes that they could never get into, depending on whether they're on high doses or low doses of steroids. And all of these burdens of adjustments, having to think about exercise, diet, being careful to avoid knocks, reduction in hobbies. People even talked about postponing important events such as graduation or weddings until they could get off the steroids because they just didn't feel like themselves with the appearance changes. People also, particularly our patient partners, but also in the interviews, talked about how they'd very rarely had this explained to them up front. So very rarely had a doctor actually said, we're giving you these steroids, but they may affect your mood, they may affect your sleep. Sometimes sleep was talked about a bit more, but they rarely said that this might result in changes in your face or your body and your weight. And people felt that, particularly the patient partners, were quite strongly that doctors and clinicians should be a bit better at proactively warning people about this. So what we've then done is we've drawn up like a card, which our researcher Steph has done, which is basically this square, which is to give to doctors and nurses to say, we know that this could be a bit awkward to talk about because there's sometimes a bit of a taboo about the change in appearance, but actually patients want somebody to talk quite honestly. The quote that we have here was, I wish that the doctor had sat me down and said, look, we're going to put you on prednisolone and this is what could happen. So we've actually got a load of these cards, so if anyone wants to have a look at and send Steph some feedback on this, we're hoping to incorporate this into a later paper, but really the aim is to try and educate the health professionals about what they should be sharing with patients. So the fact that steroids can cause changes to your face and body, they are essential treatments, but they can have side effects in the higher dosages. Sometimes they can increase appetite and lead to weight gain, and this can be helped in part by eating a healthy diet. But also it's important not to make people feel bad about this because they're already being treated for a serious disease, but also that it can impact mood and sleep, and so just try and be kind to yourself. So as Professor Sid was talking about right at the beginning, be gentle on yourself and get support from family and friends, because we know that people are dealing with multiple different aspects all at once, really. So I'll leave the cards at the front if anyone's interested in having a look and giving us some feedback. So lastly, I think I've just got time. I'm just quickly going to talk about some focus groups we're doing. So we know that patients with vasculitis, inflammatory myositis and systemic sclerosis and Sjögren's in the UK, there doesn't seem to be any kind of support interventions or packages like there is for, say, more common diseases like asthma, or if you've had a heart attack, you often go to like a rehab kind of course. And even in rheumatoid arthritis, people who have fatigue, quite often there's lots of initiatives to try and give some self-management support about dealing with having a new disease. And we know that there's a patient survey that was performed by the patient group in the UK of more than 2,300 members of people with vasculitis, lupus, inflammatory myositis, etc., reported that 60% were struggling to cope with their condition, 45% had reduced or stopped work, and 45% had felt that their health condition had negatively impacted their family. So we went to do a survey of NHS rheumatology departments to say, is anyone offering any support for this more psychological aspect? And more than 80% do not offer any access to any self-management support to people with these rarer forms of vasculitis or lupus. Obviously, the NHS, like a lot of healthcare systems around the world, is under immense pressure. And the feedback that we got from sort of funders and commissioners and NHS managers was that there would potentially never be a situation where we could offer something that was only for one particular type of a rare disease. So that led us to say, well, could we offer some kind of intervention across different diseases? Could support for people with different rare diseases be given together? And would that sense of isolation be reduced by, like today, bringing people together? They may not have exactly the same condition, but some of the aspects might actually be might have a lot of commonalities. What could this support look like, and what would it be important to include? So again, we advertise via Vasculitis UK and Lupus UK, Myositis UK, etc. in the UK. And we organise 6 online focus groups with 26 patients in total. We have people with a range of different diseases, so 6 had vasculitis. We also had lots of patients with lupus. Most of the people were female, however, and more than 80% were Caucasian ethnicity. So we knew that this was a bit of a limitation of our study, but that was the sample that we had. And we've analysed this with one of our professors of psychology from UWE, which is where I'm based in Bristol. And we found that there's a real overarching theme, which is that everybody with one of these diseases knows that they have something that's quite rare. They're quite often being told that a lot, where people don't know exactly what it is. It's quite clinically complex, and it's all about autoimmunity. And these 5 different aspects underneath it falls underneath it. So I'll just show you a few of the quotes, because I think I'm just a bit running over time. So the autoimmunity side of things, the fact that it was very rare, it quotes that people said were, I think if you have a very rare condition, you need other people who've got similar problems to you. And you can go and see a rheumatologist, and they've never seen a patient like me in their life, which I think people quite often find, particularly on the path to diagnosis. There's a problem with managing healthcare systems and professionals, which is definitely a problem in the UK, because we often have different specialists working in rheumatology or nephrology, and then if you have like a ENT problem, or if you have a neurology problem, you have to go to maybe different hospitals to see people and linking things up. So one quote that somebody says was, I'm constantly doing medical admin along with surviving and fighting a disease. And 3 hospitals, 6 specialists, I'm managing them, and I don't have time to be a patient. There's a luck of the draw, a real variation in access and resources. For example, again, there was somebody who said the rheumatology department there effectively didn't know what vasculitis was. And I travel from X to Y because they seem like they care more than the people I saw in my original city. Also, people reported from this focus group sample, we're all middle class. What about the people who haven't had the education or help to kind of try to navigate through all of this? People reported that they were anxious about misinformation out there on the web, but also about the sources of information, like Health Unlocked in the UK, and the patient forums were excellent in terms of providing support. And the fact that sometimes people might be giving out information that wasn't completely reliable, they were very concerned about. There's also a big focus on, well, I know that my doctor's mainly focused on the clinical side. What are the blood tests telling me? What are, have I got osteoporosis? Have I got this or that? But do they have any time to kind of focus on the quality of life side, which is not really kind of that commonly focused on at all. So, for example, I get 15 minutes to talk about everything to do with my lung disease and my muscle weakness and my heart condition. So I don't want to be getting into this stuff about incredibly fatigued I am, the destruction of my life that this condition has brought about. But then, where does it go? I just don't. There isn't anywhere to take it. And the quality of life is not something that is in there for them, the doctors, and that's what is wrong with me. Dealing with the emotional fallout was really significant. Effectively dealing with the grief of losing part of your life or the possibility of part of your life, and the fact that people had to change their life and their partner had to change his life as well. One of the quotes was, you feel guilty and you feel like a burden and you feel like you're so rare that you can't really tell anybody about it. So in conclusion, these topics really came out across the rare rheumatic diseases. So for people who've got vasculitis, but also lupus and scleroderma, and certainly in the UK, the specialists and patient groups, etc., tend to be quite in a bit of a silo, so they focus on one disease area. So our sort of plan is to develop this theme to see whether we can develop some sort of support intervention which can bring people together and to be feasible and effective for use in even a tiny NHS trust, which might have not a lot of resources, so not just in real specialist centres, but also in what we call district general hospitals. Our next steps are to try and collect data from other people who may not have been included in the research before, and to identify the kind of intervention components, so what people were mentioning about the exercise and the fatigue, likely to be kind of sort of brought from either like things like chronic fatigue or possibly the fatigue that's seen with other inflammatory diseases such as rheumatoid arthritis. There's quite a lot of evidence about the benefits of fatigue management, and also things such as acceptance and commitment therapy, which is a bit like CBT, you may have heard of, but it's where you're not dismissing the fact that things have changed, and it's almost a way of trying to move from a position of real grief about getting a new diagnosis and having to live with it, to how to work around it to get the most out of what you want out of life. And our patient partners feel that this is a big aspect that's important to them. How to deal with family and friends. There's also some information about the diseases, which is really important, so you don't feel so isolated, and how much diet and exercise to do, and how to deal with things like work and finances, as well as the self-management side of things, such as fatigue and pain, which we can draw on other conditions. So there's a lot of evidence out there, but it's just not really been put into practice so much as in vasculitis. And this is just an overview of our potential intervention. I won't go into, but I'd really like to get people's thoughts on either the steroid stuff that presented or the fact of this supportive interventions, and whether people had any in Spain or other countries, and what they thought of that, whether it would be beneficial. So that's it. So yeah, I'm not sure. Yeah, that's okay.
I will try to take some questions from
Yeah,
them
yeah.
and translate
Thank you.
them back to you. Como habéis visto, muchas de las cosas que han salido en vuestras conversaciones, existe un esfuerzo por entenderlas mejor, por saberlas tratar, aunque muchas veces no lo sepamos. Y aquí tenemos todo el esfuerzo que está haciendo la doctora Robson y su equipo para poder en el futuro manejar mejor todos estos condicionantes de la enfermedad que pesan mucho, además de los problemas estrictamente médicos. ¿Alguna pregunta?
Ha hablado muy claro, todo. Yo creo que preguntas aquí no puede ser, no lo sé. Si alguien tiene una pregunta, por favor.
She says that you explain so clearly how all the people in this room feels about their disease, their social impact, personal impact, and all these things. That she says that there's nothing additional to ask or to say. And it's very important that physicians start caring about all these things, even if we don't know very much how to
The next step
help.
is still tricky.
At least there are little things that all of them can add. So,
Thank you very much. Yeah.
sí.
Como se ha estado nuestra piel, como se dice, como
She appreciates.
siente todo.
She appreciates how you have put yourself in their place.
Oh,
You
that's
know
good.
how your empathy about what a patient may feel.
Oh,
Yeah.
thank you very much. Thank you. Okay.
Bueno, yo tenía una pregunta. Por el tema de especialidades, hay una serie de especialidades que por la enfermedad que tienes, ¿no? En cardiología, los que son trasplantados o les han hecho una intervención cardiológica, tienen normalmente un soporte, ¿no? Que es lo que decimos entre diferentes partes, que es normalmente un psicólogo y normalmente un seguimiento con enfermería, que a mí me lo están haciendo desde cardiología. Pero realmente mi enfermedad, aunque tenga efectos secundarios en otras ramas, es de reumatología. Reumatología, por ejemplo, creo que en general aquí falta este soporte. No sé, mi pregunta es, en otros hospitales, que no sea el mío, ¿no? ¿Existe esta intervención en diferentes aspectos, psicológico y de enfermería?
He's asking if in other places there is if there is this multidisciplinarity that helps many aspects of the patients. Particularly, he's advising psychologist support or nurse support that can help with following a diet or following an exercise program. So how this is implemented in other countries?
Yeah, so it's a good question. So we did the survey and we found that more than 80% didn't have any psychology support. In the UK, I think nephrology, so renal doctors, because people may be on dialysis, they have quite commonly got a psychologist on board. But in rheumatology, it's something that locally and nationally is a real lack of, but we do have excellent specialist nurses. But again, there are barriers to sometimes getting them involved in vasculitis. So sometimes they go into it and do rheumatoid arthritis and they're very comfortable. But sometimes the nurses tell us, this is a bit scary, we don't really know what this disease is about, and they're rheumatology nurses. So we're also trying to bring along the nurses and get them to sort of lead on some aspects as well. So I think that's really, really important. So thank you, yeah.
Sorry, Joe, thank you very much for a great talk as always. Is the steroid toxicity PRO available now?
Yeah, definitely, yeah.
So we could, as a patient organisation, some of our members could use that?
Definitely, yes.
Because I think it's going to be a really good tool for both patients and the healthcare professionals. So.
Definitely, yeah. And we're looking to potentially do some studies looking at it as a communication tool. So in terms of people being able to take those questionnaires and go, and then the doctors say, okay, I can really see this is impacting on psychological well-being. Perhaps we should be reducing the steroids. Perhaps we should be trying to address that. So that would be great. Yes, definitely.